Topic today is stages of change and the spirit of motivational interviewing. And I want to make sure to give credit to those who originally developed these slides or the slides from which these were adapted at UNM's ASAP clinic. And that's Dr. Bott, Dr. Fernandez, and Dr. Lindsay. So our objectives today are we'll start out by identifying the core concepts of the transtheoretical model of change, specifically in order to apply these concepts to assessment and treatment. We're going to review the foundational principles of motivational interviewing and its basic components as they apply across clinical settings. And we're going to work towards developing an understanding of the philosophy and the application of motivational interviewing in the context of case conceptualization and treatment planning. And I'll say this is entirely meant to be an introductory overview, and we do have some resources at the end of trainings that you can attend very soon if you're interested in really getting trained in MI. All right, so we'll start out with this trans-theoretical stages of change model. It's an evidence-based model that matches where a patient is at with what they need in order to benefit from treatment. And that might sound really simplistic, but if you've attended a lot of these presentations, you've already heard about how undermatching and overmatching for treatment can actually have really significant consequences for retention, adherence, and outcomes. So this is really a very valuable model in that sense. The stages of change model is very frequently talked about in the same breath as motivational interviewing, but they are actually separate things. Motivational interviewing will be the second half of this presentation. They go together very nicely for a variety of reasons, but it's important to remember that they are two distinct models. That being said, the stages of change model is such an excellent guide for assessing what type of intervention will help most, and we'll talk more as we go through about how it fits with MI in particular in that sense. So in a moment, I'll dive into the details of the characteristics of the different stages of change, but I do want to start out with this sort of aerial view of how they fit together. And something that's important to remember about how these stages are related is that even though it's usually represented in this graphic where it has the clockwise arrows linking all the stages, they don't always proceed in exactly that direction or that order. In fact, it's very common that patients will sort of enter and exit the model at different junctures. So I always want to preface it this way because otherwise sometimes providers worry that they're using the model incorrectly or there's something very unusual about their patient. It's really just presented this way because it's the easiest way to learn it, and it makes a lot of intuitive sense how these fit together. The second thing that I want to note before we dive into the specifics is you'll see in the middle here that there's the upward spiral, and that relates to that stage of relapse in the upper left-hand corner. And the idea there is that patients very often think when they hit that relapse stage that they've done something wrong or that treatment isn't for them or that they're a failure. And that is not the case. And that's so important for us to communicate to them as providers. It's a very, very normal part of the recovery process. And we'll talk more about that in a bit. But a conceptualization that can be really helpful that a lot of providers use with this model is that of a spiral staircase. So patients and providers both can feel a little demoralized when they feel as though the patient is continually returning to the same point in the model, to the same sort of perspective or challenge. And as long as we can give them this conceptualization that yes, it is a circular movement, but it's a spiral staircase. So as long as they are learning each time, they are in fact moving upwards. So they're returning to the same point, but it's at this sort of higher plane in the staircase because they're armed with all of the lessons that they learned from relapse and from the other stages. So we'll talk more about that in a bit, but I do think that's a really important thing to keep in mind from a conceptualization standpoint as we go through more of the specifics, that fact that we're always moving upward as long as we're learning from each stage. So the pre-contemplation stage is where a person might not recognize that there's a problem, or if they do, they're not really thinking in any serious way about changing it. Very often at this stage, the person is attributing the problem to external sources. So this is somebody who might be saying, it's not my use, it's the problem, it's other people being judgy and not minding their own business. So your goals in this stage are really about bringing awareness of that problem closer to the surface, because it's usually here buried under a lot of sort of defenses and fear potentially. And that way the person can start thinking about it in a conscious, intentional way, rather than just being reactive around the subject. And really your guiding star here is that you're keeping the patient engaged in the process. So it's a very, very relationally rich process. You're doing this through listening to their concerns. You're making sure that you're reflecting the content that's most important to them, and particularly reflecting the emotion that's connected to the problem as they mention it. You want to elicit as much information as you can that's relevant to the problem. So that has to do with, what are their past experiences? How has it affected them? And in particular, you want to talk about strengths and triumphs. And this, we'll talk more about this momentarily. But very often, what undergirds some of the difficulties in moving towards change has to do with a lack of confidence. And so we're constantly looking to bring the patient's attention to their strengths and their resources and things they've done in the past that prove to themselves that they can make great decisions for themselves, that they can do difficult things. And through all of this, you're always communicating caring, the empathy, the honesty, the acceptance, and remembering that with substance use disorders population in particular, a lot of their contact with the healthcare system is likely to have come along with stigma and alienation and other things that have made it difficult for them to keep engaged. So you're giving them a very different experience in this way. So with contemplation, and I'll mention this sort of foreshadowing that this is the stage where motivational interviewing is the gold zone. This is where motivational interviewing really gets traction. This is where a person is willing to think about making a change, but they're not ready to do something about it yet. So the phrases that often go along with this are being of two minds about something or being on the fence about making the change. And your goal here in contemplation is to help very, very gently help the person move towards action. And so part of how you're doing that is selectively reflecting what they are talking about so that when they're talking about the status quo, about the old health habit, you're not ignoring it, but you're certainly not reinforcing it. Whereas when they start to talk about that change, anything that has to do with making the change, you're really leaning in as the provider, showing them a lot of enthusiasm, asking them a lot of follow-up questions so they know you're really interested and helping their mind to spotlight that change option more. A part of the process that you're incorporating here is that you're wanting to help them become more aware of all of the options that represent change in their case. You'll notice that a lot of patients, especially with substance use disorders, come in with a really monolithic idea of what change looks like in recovery. Oftentimes, this comes from the movies or maybe from an outline representation of somebody they know. And they'll think that recovery means going cold turkey that day, or something that's similarly, a very, very large goal. So helping them to understand that there are many ways to move towards change and presenting them with a sort of buffet of change options is one way that you can make sure to make it a lot less intimidating to them. So very often that's a harm reduction approach. So that could look like for somebody who's pretty avoidant, maybe has multiple comorbidities and is really nervous about making change. It could be just having the conversation of what would it look like to go from using 8 grams to 7.5 grams in a day. And in that way, expanding their idea of how incremental change is helpful. At the same time, you're increasing their perceived benefit of change, and very importantly, you're grounding that in what they have told you about what's important to them about it. So when they're talking and you notice that there's this sort of discrepancy between what they're doing now and how they want to be in life and what their goals are, you're just very gently bringing attention to that because they know it in a sense, but perhaps they've been afraid to confront that discrepancy. And with your gentle support, they can take a more honest look at, how is the status quo not fitting with who I want to be as, say, a grandparent or a partner or whatever the relevant role is, or how does it conflict with the values that are most important to me in life. In terms of supporting self-efficacy, again, this goes back to the lack of confidence that so often shows up during these stages. You really want to cultivate their recollection of past successes, cultivate that sense of optimism, help them to recognize their internal resources that they may be disregarding. And in particular, you're shoring up their decision-making ability and their autonomy. Because one of the things we'll talk about more with motivational interviewing is that the more in control they feel in terms of making the right decisions for themselves, the less effort that's expended on defending the status quo or the old way. And then lastly, when you notice that there's discord or any kind of argumentation coming up, that is a sign to you as the provider to change tactics and to move back into the pre-contemplation strategies. So we're not at any point in contemplation trying to argue or coerce or cajole. What we're really trying to do is come alongside. And so anytime we find ourselves in this sort of perpendicular position of arguing, we take that step back, we apologize, we affirm, we accept. We're reflecting the patient's concerns to make sure they really know we're genuinely listening, we're learning from what we didn't hear the first time. And an important verbal strategy here that's particularly useful in contemplation, but in fact is useful in most places in treatment and general life, is to switch out the phrase yes, but for yes, and. And this is really interesting psycholinguistically in itself, but the big idea is just that when people hear that conjunction but, it prepares their brain for an argument. They think this person is contradicting me and I need to sort of set up my defense of my argument. Whereas when they hear and, so for example, we're saying, yes, everything that you said is totally true and that makes a lot of sense. And also, I wonder if you've considered dot, dot, dot. Then typically they're going to perceive that as you, as the provider, adding something to the picture rather than contradicting their own vision of the situation. And that way they're able to be more relaxed and receptive rather than being in that mode of digging their heels and defending their own position, their original position. In the action stage, the person is ready to make an initial attempt to change behaviors, but they might not yet be confident about their abilities to succeed. So, as a provider, the goal is really to smooth the path to change in any way you can. You want to be the cheerleader, encourage all bits of progress. Anytime you can anticipate barriers, you want to problem solve and add skills where necessary to reduce those barriers or remove them. And a counterintuitive piece of the action stage as a provider is very often patients will, they've got the momentum, especially if they had a rich, experience in the contemplation stage. They're really excited to just dive in, and sometimes they make goals that are just plainly unrealistic for themselves. And so, without taking the wind out of their sails, you want to make sure that you set them up for success by troubleshooting with them. What is realistic for your resources and your circumstances right now? Because you want to make sure they taste success right off the bat in the action stage in order to sustain them. In the maintenance stage, this is where a person has already made significant changes with concern to their target health behavior, and they're integrating those changes into daily life. Something that Di Clemente, one of the main developers of the model, points out is that maintenance is really kind of a nuanced stage more than we often appreciate. It has a sort of long runway, so to speak. So you're in maintenance when you've made those change and you're integrating them, but he says, you don't consider yourself to be fully stabilized in maintenance until those new health behaviors are completely automatic. They're effortless. You're no longer thinking, I'm not doing things the old way, I'm doing things this way. It's just how life is. So the goals during maintenance are to sustain motivation, because this is sort of the just long, dirty leg work of recovery, and people often lose motivation. To identify triggers that could lead to relapse, this is an important part of that critical relapse prevention planning. You're developing a plan for coping skills for any triggers that can't be reduced or avoided. And then also you're going to plan for relapse, essentially. You'll remember on that graphic that relapse was classically represented between maintenance and pre-contemplation. You're going to predict it for them. You're going to help them understand that relapse is very, very normal, and you're going to help make a plan for how are they going to re-enter the cycle of change where they want to be at if relapse occurs. So I'll talk about that a bit more with respect to the abstinence violation effect here with relapse. Again, I can't emphasize enough how important it is to provide that psychoeducation to patients, that relapse is very, very common, much more than normally the exception in the process of recovery. It's not catastrophic, it's not a sign of failure. And it's helpful a lot of times to patients to point out that it's part of the recovery process for any health behavior, any type of chronic illness. So whether people are trying to change their habits around sleep or diet or anything in the wide range of chronic illness and health behavior change, a return to the old behaviors is a very normal part of that process. And it's important to remember that the language that we use, those are verbal strategies. Those are interventions in themselves. And it's very, very important to situate relapse as a learning opportunity, that when patients reach the point of relapse, this is sort of the richest juncture for them to be able to identify what was missing in their treatment approach the last time around. So looking back, what were the yellow, orange, and red flags? How can we adjust the treatment plan accordingly? One of the most important components here is that abstinence violation effect that I mentioned. So the abstinence violation effect refers to the experience that most people have at that juncture of relapse, where they have the thought, I messed up, I've lost everything, it was all for naught, I might as well go back to the old way. It's that hopelessness that makes people feel like they just need to give up. And when you can predict and let them know that's a very normal response, but it's not necessarily accurate, and they can think through this ahead of time in a safe, supportive clinical environment, then that allows them, when the moment arrives in real life, to recognize, oh, this is that abstinence violation effect, and I do have a choice, right? It's not, I don't need to give in to that feeling of it's all over and I might as well go back to all the old ways. And it's really helpful to use experiential language here. A lot of patients will recognize metaphors like, you're on this road and then relapse is a detour, but you get to decide whether you go to a completely different destination or if you just make it a little detour and get right back on the road. Whatever kind of language is going to fit that patient's experience. But again, you want to make sure they know that that's likely to come up with relapse, and help them decide ahead of time how they want to address those thoughts. So your overall goals, again, are helping them to avoid becoming discouraged and helping them to re-engage skillfully in the change process when relapse does happen. So I'm going to turn now to motivational interviewing and to the spirit of MI. I was diplomatically informed recently that for most physicians, MI means myocardial infarction. So I'm trying to remember not to use the acronym too much, to keep it from being too confusing. So the big picture with motivational interviewing is that it's an effective method for talking with people about change. And the emphasis there is from the developers, Miller and Rolnick, who it bothers them a lot that they often hear MI used as a verb, as in, I'm going to MI somebody, because that is a very domination oriented way to view the process that's really antithetical to its spirit. It's a collaborative, person-centered form of guiding in order to elicit and strengthen motivation for change. So again, it's not persuading or cajoling or coercing. It's really that facilitative role. And also it's a clinical method that's used when a person may benefit from making a behavior or a lifestyle change, but they're reluctant or they're ambivalent about doing so. And motivational interviewing is there to help them think through the process. So it might seem weird to talk about what a motivational interviewing is by talking about what it's not, but this is from an essay that the developers wrote a little more than a decade ago because they noticed motivational interviewing had become so ubiquitous, and this is part of, they had decided not to make it proprietary, but that gave them very little control over quality control. So they really wanted to differentiate all these things that they heard being referred to as MI that were not in fact MI. So as we discussed before, it is not the trans-theoretical model of change. It comes from a similar body of research in the same generation of research, but distinct entities. Very importantly, it's not a way of tricking people into doing what you want them to do. And unfortunately, I do hear providers sometimes refer to it this way. When we have seen motivational interviewing very skillfully deployed, it can look kind of like magic. It can look like somebody just got tricked into doing the thing that the provider wanted them to. But that's really just maybe what it looks like on the surface, because as we'll talk about in a bit, the spirit of MI really prohibits us from doing anything that's inauthentic or deceitful. 3, it's not just a technique, and we'll talk about that more in a bit. There's a lot of technical elements that go into motivational interviewing, but they are all tied into the spirit of motivational interviewing. 4, it's not decisional balancing. This is one of the interventions that has become synonymous with motivational interviewing. It's a sort of a pros and a cons list. But of course, MI is quite a lot more than just that. That's just one that has become synonymous with it. It's not assessment feedback. That misunderstanding, I think, comes from some early trials where motivational enhancement therapy, a very closely related approach, was developed, and that incorporates assessment feedback. It's neither cognitive behavioral therapy or client-centered therapy. The developers have backgrounds in both, but it is both much less directive than cognitive behavioral therapy and somewhat more directive than true client-centered therapy. And it's not easy to learn, and it's not practice as usual. You'll notice that clinicians who don't know a lot about motivational interviewing will sometimes, watch videos or hear about it and say, oh yes, I do a lot of those things, because there's a lot of clinical intuition that goes into it. But if you receive training in motivational interviewing, you'll realize that there's a lot going on beneath the surface that's very skillful. It's not just kind of what it looks like up top. And you'll realize that much of the skill comes with what is not said, or the timing of what is said, and even the inflection, rather than just the interventions themselves. And then lastly, it's not a panacea. And that kind of goes along with number 2, because again, when people see it done really well, it can just be revelatory, and often providers then want to use it everywhere. It's the hammer and nail kind of phenomenon. But as I mentioned before, contemplation is really the only stage of change where motivational interviewing is likely to be helpful. In most other stages, it actually can be counterproductive. So there's very much a time and a place for motivational interviewing, and it's not going to work out the way we want if we don't adhere to that. All right, I'm pausing for a moment to see whether we have a case. All right, I'll check back.
No, we don't have a case.
Okay, thanks so much, Rachel. All right. So with the research evidence on motivational interviewing, and this is something, this is a reference slide. If you're interested in diving in deep, please do. It's quite interesting. The sort of takeaway headline is just we have several decades of research evidence to back up that motivational interviewing is very, very effective across a variety of settings, a variety of presenting problems that relate to health change behaviors. But I want to draw your attention to a couple particular points here that I think are really illustrative of how powerful and how unique motivational interviewing is an approach. So one of that is that just adding motivational interviewing to the beginning of treatment in this meta-analysis led to sustained outcome improvements. So it can be incorporated, of course, with a variety of other approaches, but it's just that important ingredient at the beginning to really galvanize people's motivation. And what they found is that actually, those effects are evidence across treatment, that the motivation was curried very well at the beginning. And then the second one in yellow there, I think this is so interesting, and I think it's very, very illustrative in itself of how important the spirit of motivational interviewing is that with this early meta-analysis back in 2005, they found that outcomes were better when no manual was used. And that probably is surprising when you dig into the research on this. It's so interesting. This was at a stage where motivational interviewing was still being piloted. And so at that stage, they had a version where they took more of a cognitive behavioral therapy approach, and they incorporated a required change plan at the end of each session, whether or not the patient was ready for it. And so, of course, what we know now with our wealth of knowledge retrospectively on motivational interviewing is that really is counterproductive to the idea of following the patient in terms of their stage of readiness. So the providers who were not using a manual and were really just tuned into the spirit of motivational interviewing actually had better outcomes because they were using that clinical judgment to assess at the end of each session, is this patient actually ready and receptive to a change plan? And if not, making sure that they took their time and adhered to the appropriate interventions for where they were at. So I think that's really interesting because it just shows how important being tuned in and honoring the spirit of motivational interviewing is in terms of not moving ahead too quickly if the patient's not ready. And then with that second, somewhat more recent meta-analysis, this was for RCTs for health behavior outcomes, and this was with the primary care population. I want to point out the effect sizes for motivational interviewing were largest for outcomes related to weight loss, blood pressure, and substance use. And that's exciting because I think probably most of us here recognize those are particularly difficult outcomes to change. Those are fairly intractable. So it really says a lot about the potency of motivational interviewing, and also that it's useful in as few as a single session. So that's, of course, why motivational interviewing is very popular in primary care, hospital settings where we may only get to see the patient once or very few times, but it can be quite effective even just in a single session. Culturally adapted motivational interviewing is something that really warrants its whole own presentation on its own, but I did want to put it on your radar because I think it's a really exciting new direction of research for motivational interviewing. And the idea here is that there is some evidence that motivational interviewing is even more effective with patients from a racial ethnic minority population. The theory is that because it's so focused on individual values and goals, and it's very patient-centered in this way, that it manages to avoid some of the pitfalls of other mainstream approaches that have a lot more mainstream culture values embedded within them. So with culturally adapted MI, there are three dimensions to it. There's content, concepts, and context. And just as a very brief overview of how these fit together, the idea is that with adapting motivational interviewing to a particular population, you want to consider first literally just the content of the kind of health literacy that you're including in the intervention, so that you're honoring unique cultural values, customs, and traditions in the treatment planning. And an example I thought that was helpful here was these providers who were working with American Indian and Alaskan Native patients realized that tobacco cessation interventions, as they were originally formed, included a lot of very negative treatment messaging around the role of tobacco, and they didn't acknowledge that in these communities there's some very, very positive, important traditional, ritual, and spiritual roles for tobacco. So that's simply from a content level a really important shift to make when implementing motivational interviewing with this particular population. With concepts, this is about making sure that you align the treatment model with cultural importance regarding specific character traits, the importance of cultural values. An example that I really like here, because there's actually a lot more qualitative research on this particular aspect, is the importance of framing substance use disorders as a community level disorder that stems from disparities between Black and white American communities rather than as this individual level pathology. And so bringing in that sociopolitical and the historical context of how substance use disorders emerge really helps to dispel some of the shame and the pathology around that anachronistic conceptualization of it as an individual level disorder or failing. And then context, of course, any type of multiculturally responsive treatment, it's important to consider the context. Here, some of the main ones are making sure that you're considering a culture of stress if this is somebody who is somewhat recently arrived, availability of positive social supports, economic or political macrospheres. So in other words, kind of what are the nested larger influences in which this patient is ensconced, and their relationship to the country or the culture of origin. So I think in some ways that's intuitive, but this is sort of a structure to make sure that motivational interviewing is being adapted appropriately to the values and the goals and the cultural frameworks of the particular population that's experiencing treatment. So now we've talked a little bit about the big idea of motivational interviewing. Now we'll talk about the spirit of motivational interviewing. And this quote from Blaise Pascal from several hundred years ago, I think, is a great way to distill the spirit of motivational interviewing. He said, "People are generally better persuaded by the reasons which they have themselves discovered than by those which have come into the mind of others." So we've known this for a long time, but this really encapsulates that idea that if we can elicit a patient's own motivation, their own reason, and their own values and goals related to change, that's going to be so much more potent than us just giving our own reasons that we think fit for them. So we'll look here a little more about how we do that with the spirit of motivational interviewing. One of the things that's important is, as we talked just from the bottom up about spirit of motivational interviewing, is that ambivalence is an absolutely normal part of the process of change. And while ambivalence often provokes exasperation or frustration or other negative feelings in us as providers, motivational interviewing encourages us to really lean into it, to appreciate that ambivalence is part of the process and to work with it skillfully. So when we're talking about ambivalence, we're talking about feeling two seemingly contradictory things at once. So that's that kind of being of two minds about one thing. And a lot of the times it's going to look like lack of motivation. And it's easy to blame it on that as a provider when it's actually about this internal struggle where there may be motivation that's being obscured by this tension between wanting two things at once that can't coexist. Again, it's a normal part of the change process. It's very, very common, not only prior to, but also during behavior change. It's not as though ambivalence gets resolved once and never comes back. It tends to pop up frequently. And one of the most important things we can remember about ambivalence as a provider is that it tends to tempt us into something called the communication trap, which is where we argue for the side of the fence that we want the patient to land on, and that in turn prompts the patient to defend the status quo, the other side of the fence. This is very much human nature. Psychological reactance is its own whole field. It's really fascinating, but the idea is it's just a very natural response for humans that when somebody argues one side of a issue, that we are drawn to defend the other side. And of course, when the patient is defending the status quo, that is going to make change less likely, hence the trap. So the writing reflex it sort of describes this instinct of ours. We're healthcare providers generally because we care about people and we want things to be better for them. So this is a very well-intended inclination that we have to want to make it better for our patient. And the danger that's inherent there is that it often leads us to want to tell the other person what to do, how to do it, why they should do it, without taking the time to really talk to them and learning what they think and what their reasons are. And we'll talk a little bit more about how we do that in a moment. But the idea is that it does create resistance in the patients because we're moving away from that collaborative alongside partnering stance that's inherent to motivational interviewing. And we're shifting into an expert top-down sort of authoritative role, which tends to elicit a lot of resistance from any person, but particularly this population. A lot of the assumptions that undergird the writing reflex have to do with the belief, they just don't see, they don't know how, they don't care. And this leads us to the conclusion, if we can just give them the insight and the knowledge and the skills, then we can make things better for them. And these are, for the most part, erroneous assumptions. Some of the consequences of the writing reflex are that the patient is going to make a change briefly to satisfy us. So it could be we have great rapport, they want to be, a good patient, but it's not for their own benefit, so it's not going to stick. It's not tethered in their intrinsic motivation. Another is the patient listens politely and proceeds to do whatever they were going to do in the first place. So it's really just kind of they're just getting through the conversation. Potentially the patient protests and we push harder, and that starts that internecine cycle that I was referring to, where no one benefits. It's very easy as the provider blame the patient and say it's because they're not motivated, when in fact it's because we haven't created those conditions for change by exploring the ambivalence and supporting them in their own decision making process. So I think this graphic is helpful just to remember and to sort of recognize it as it arises, that that writing reflex is a very natural instinct for people who care, but that when we're using it to meet ambivalence head on, we're actually going to strengthen that muscle of defense. So using the writing reflex ultimately is very counterproductive to our purposes. A way that we can help this, you'll notice that motivational interviewing loves their acronym, is the rule of MI. So R is about resisting the writing reflex. So that's just knowing that that's there, that it's likely to happen, recognizing it as it arises so that you can pause and take a different tact. And the different tact is that you're understanding and you're listening. So you're really taking that deep dive into the patient's motivations and returning to that elicitation discussion of why is this important to you? What have I missed? And making sure that you're tuning in and getting to the same page. So you're both getting the information that you need and you're also communicating to the patient that you are their partner rather than trying to tell them what to do, and that you're in this with them in a collaborative stance. And in that way, you're empowering your patient. You're saying, I'm not making these decisions for you. I'm just here to support you in making your own decisions. Because again, that self efficacy and the sense of autonomy and agency that they experience when they are honored as an individual decision maker, that in itself dramatically reduces their defensiveness and increases their ability to think in a conscious way about what they want to do next. When we think about the components of MI and how they fit together, the developers always want to emphasize that the spirit, even though it seems simplistic, is the absolute foundation of all of the other components. So you may be quite skilled with the principles and the processes, the skills and the techniques, but if they are not all informed by and anchored by the spirit, then they're hollow shells of interventions, because it's the spirit that really guides what motivational interviewing ultimately means about respecting the autonomy of the patient. So I do want to emphasize, if you do choose to go ahead and actually get trained in motivational interviewing, that is so wonderful, and I really encourage that. That's where you'll learn a lot more about the principles, processes, and skills and techniques. But as far as what you can do just with what you have here, the spirit of motivational interviewing in itself is so powerful for helping to change the types of conversations that we have with patients around health change behaviors in a positive way. So the constituents of the spirit of motivational interviewing are acceptance, collaboration, and evocation. That's acronymized as ACE. So acceptance is a counterpoint to authority. In an older medical model, the idea was really we need to sort of override the patient's perspective and sort of insert our own reality, so to speak. Whereas with acceptance, we're going really to the other end of the spectrum, and we're affirming the patient's absolute worth by communicating positive regard, irrespective of what their behaviors are or how they fit with our long-term goals. So you're communicating that respect. And the paradox here, it's called the Rogerian paradox, is that when people experience being accepted as they are without somebody trying to change them or judge them, that actually frees them up to change rather than becoming more attached to or feeling that they need to defend their past self or their status quo. Part of how we do this is by using accurate empathy. So that's not just being empathic, that's really striving to make sure that we have accurately understood why this is important to them, what's on the other side of this health change for them, based in their own meaning and their values as an individual and within their culture. Again, the autonomy support, I can't emphasize enough how important it is to acknowledge their freedom to make choices and to acknowledge that their attitudes and their behaviors are their own choices. Again, the more affirmed people feel in their autonomy, the less defensive they are about accepting this facilitation role to help them make their own decisions. And then, of course, affirmation, and that's that sort of cheerleading component of motivational interviewing where we're just actively communicating appreciation of their strengths and every incremental effort that they make towards change, however small it may seem. With collaboration, the counterpoint is confrontation. So again, in that older model, there's that idea of I'm the provider and I'm here to tell you what to do, what you're doing wrong and what you need to do differently. Whereas with collaboration, it's really visualized as a collaboration between experts. They are an expert in their own life. There's many things we're never going to understand about their life that they know very well. We're the experts on behavior change, as the case may be. So this is more of a dance than a domination-oriented sport like wrestling, where we're trying to create something together that's a synthesis. And it really is at its heart more about exploring than about persuading or, trying to get to an ultimate outcome. So just coming in with that gentle curiosity in itself is the sort of superordinate intervention to make sure that we're communicating that spirit of motivational interviewing. Again, the language here is important. The developers, Miller and Rolnick, really emphasize that MI is conducted for and with a person rather than to or upon them, which some people are inclined to use that language. But again, always keeping in mind that the stance is alongside, not above. And going back to that idea that patients are the undisputed expert on themselves, they often already know what they need to change and how to do it. And your role there as a facilitator and a guider rather than giving input per se. Lastly, for E, evocation is a counterpoint to education. Again, that older model prompts us as providers to say, this is the information that they're missing. And if I just give them this information, then that's going to make the changes that they need. With evocation, we're really focusing on the patient's internal resources. What they already have is everything that they need. And that as a team, we're going to bring it forth together. We're going to bring those resources and the strengths to the surface so that they're as accessible as they can be. Patients are often in this stage going to say, I'm not ready. And that certainly may be the case, but you really want to dig deeper and say and see, is it a lack of confidence? What can you do to bolster their own confidence and their resources? Recognize all of the skills they already have and what they can get from treatment to make it happen so that they don't have to wait till the moment is just right. So again, you're really just always returning to their why, to their values and their goals. What is on the other side of this change that is so important to them? Because it usually is a very difficult change, and it's important to have a big why. And if you don't understand that why and why it's important, then you're less likely to be effective as a provider. So that's really at the heart of this spirit of MI. So to tie up, this is sort of a graphic representation of that difference. With motivational interviewing, it's much more of a dance. Without, sometimes it can really feel like you're grappling with the patient to try to get them to do what you're hoping them to do. And I did want to point out in terms of resources, there's actually a training next week. It's free thanks to the same SOAR grant that we're under. And if that's too soon for you, then I did list where you can find future trainings. Motivational interviewing is just such a valuable skill. I really encourage you, if you're interested, to look into it. And then I also wanted to just let you know about an interesting instrument that was developed at UNM's CASA Institute called Socrates. I think it's for stages of change, readiness, and treatment eagerness. It's something to that effect. And it's an instrument that is integrated with the stages of change model and can help clinicians to identify what stage a patient is at and therefore what kind of treatment they're likely to benefit from.